We are now recording. Okay, hello everybody. We're gonna talk about, over the next 4 weeks, we're gonna talk about the paperwork that you're gonna be filling out during your clinicals. And here I am in your Canvas site. And just below, here's the modules that for the instructions we're going to be giving over the next 4 weeks. You probably logged on this one right here. Just below that is paperwork in a nutshell. Paperwork in a nutshell. I'm going to talk about the demographics sheet today, and I'm going to talk about the lab sheet. Next week, Bill will talk about the pathophys. And then the following week will be Eileen talking about head to toe assessments. And then the week after that, Eileen will again talk about care plan and concept map. We're not going to talk about the drug card because it's the same drug card you were using in pharmacology. So you should all be intimately familiar with that by now. So moving back up. We'll go ahead and get started. I'm going to stop. Any questions on this Canvas module before I move away from it? I'm going to show you a PowerPoint that talks about some of the more common labs you're going to run into. And this right here is the face sheet and labs example. So let me show you, first of all, this is the patient demographics sheet. As you can see, here's the blank one. And we're going to go through that right now. I put an example sheet here of face sheet and lab sheet so that you have something to work with. And I think I've got that right here. So I'm going to stop sharing and bring up the one that I've got on my computer because it will be easier to see. There we go. And see if I can make it a little bigger. There we are. So here is a copy of that face sheet, but this one's already been filled out. This is from a previous class, and I uploaded this into the module, so you have access to this if you want to use it as an example as to how to fill out your. Let me make sure it's on. It's not. I'm not sharing it yet, am I? Let me bring that up.
No, you're not.
Okay, it would help if I shared it, wouldn't it? There we go. How's that? That better?
Yes, thank you.
Yeah.
Okie dokie. This is one that was filled out by a previous student in a previous class. I thought she did a really good job, so I'm using that as the example. Of course, your student name and the date of you're filling it out is going to go up here in the top. One thing I want to point out, a lot of this is self-explanatory. But for patient initials, we only use the patient's initials. Because if we use their full name, it would be a HIPAA violation. While you're at the clinical site, you can have whatever information on that patient that you want. But the minute you leave the clinical site, you cannot leave the clinical site with that patient's name, date of birth, record number, or anything that indicates that particular patient, because that would be a HIPAA violation. So what we do is we just have you put the initials of the patient in there. Make sure you don't put the patient's date of birth or their medical record number in there. And if it's asking for it in here, don't do it anyway. And of course you'll have just their basic demographic information right here. Allergies, you want to put down their allergies. If you want, you could put what kind of reaction they have. For example, a lot of people will say, I'm allergic to penicillin. And you ask them, well, what does it do? Well, it makes me nauseated. Nausea is not an allergic reaction. Nausea is a side effect. Now, if they take penicillin and they say I break out in hives, then that is an allergic reaction. So your patients are not going to know the difference between an allergic reaction and a side effect to a drug. So just keep that in mind. Usually you'll just get this off the patient's records. And yeah, here it says reaction. So you might want to say what the reaction to whatever allergy it is. Admission medical diagnosis. When I do the when I do the PowerPoint on the labs, I'll talk more about where you can get some of this information. There's different places in their medical records you can get it. Usually the doctor's note, the first doctor's note from their initial, when they're first initially admitted to the care facility, there should be a doctor's note in there. And that's a great place to get the initial admission diagnosis and what happened. Because the doctors will write you a little story. They'll tell you, you know, patient was at home, fell down, you know, fractured left hip, whatever. And they give you a nice little story. So that's a good place to get your admission medical diagnosis. Past medical history. This is stuff that's not going on with them right now, but is in their medical history. He may have a history of a third-degree block. You can put that down here if he had it for many years and it got bad, so he came in. But this is looking like the third-degree heart block was something brand new. So that's not really a part of his medical history. That's a part of his initial admission diagnosis. So that's the difference there. Any questions on that? Nope. No. This sheet's pretty self-explanatory. Notice, you know, medical history dates, you know, when did you get it? Just month and year, you know, you don't have to be specific, you know, the doctor just wants to look on here and say, well, is this something they've had for 20 years or is this something that they've had for a month? So that's why you want to put a date down there. Surgical interventions, anytime the doctor's got to cut them open, you want to put that down here, distinguishes it from medical history. Brief summary of the client's stay in their facility. Here, a good source for this is the nurse or the nursing notes. When you go in, hopefully you'll be able to talk to the nurse who's taking care of that patient, and they can kind of let you know. What you're looking for is the patient getting better? Is the patient getting worse? What kind of problems are they having? I mean, every time our kids show up, do they have a fight? You know, just basic stuff like that. What's the doctor saying about the patient? Oh, the patient's going to be here forever, or, oh yeah, another week or two and they'll be going home. So you just want a little kind of a snapshot, not a you know, 5-page record, but just a couple lines on, you know, is the patient doing well? Is the patient not doing well? And what issues are we having with the patient? This is the kind of stuff you will exchange during nursing report. This is the kind of stuff you will get from the offgoing nurse, and this is the kind of stuff that you will be giving to the ongoing nurse when your shift is over. Cardex information, back in the days when we actually used Cardexes. Before computers, we had a little card for each patient. It was like in a Rolex type box, you know, and you would look up things like diet, OT, PT, etc. Now that's all on the computer screen. So you'll have their diet, fluid restrictions, really important for diabetics and people with kidney failure. People with kidney failure, their fluid is restricted because they can't pee it off. Their activity level. When it comes to assessing activity level, I usually look at them and figure out how they get to the bathroom. Do they just get out of bed and go to the bathroom? Then they have full mobility. Do they need a nurse to help them get up to their walker? Does it take 2 people to get them into a wheelchair? Are they totally bedridden? They can't get out of bed at all. But how they get to the bathroom is a good way to, you know, to kind of evaluate what's their activity level. PT and OT, physical therapy and occupational therapy schedule. How often are the vital signs? That's going to go by what unit you're working in. In someplace like we're at with the skilled nursing facility, they may only do vital signs once every 12 hours. In a hospital, it will probably be a med-surg unit will probably be every 8 hours. ICU unit, it's going to be every 4 hours or every 2 hours if they're critical. Cultural, spiritual, if you want to fill that out, the person may have special needs. I'm thinking when I was in Arizona that we had a lot of Native Americans, and if something went bad, they wanted us to alert their Native American church, as opposed to the Christian minister that was usually in the hospital. So different stuff like that could be important, especially if it's like, I think Jehovah's Witnesses or something where they can't take blood transfusions. So that could be important. I's and O's you record on the computer. Pain level, you always want to keep an eye on that for their level. Education level, if you want to fill that out. This kind of helps when it comes to patient teaching. You know, you're going to talk to somebody with a master's degree in biology. You're going to talk to them a little different than the person that dropped out of high school. Any particular consults coming in that day? Meds, I wouldn't worry too much about that because you're going to have scheduled meds throughout the day. Education needs, I noticed this patient needed some education on fall prevention. So evidently they had fallen down. You might want to put diagnostic tests if they have any labs that are due during that shift, any blood draws. Do they have an IV? Very important to put that down. Anything that's penetrating the body, if they have an IV, a trach, NG tube, catheter, colostomy, any of those, you want to have them in your notes because you have to pass that on to the next nurse. There's more to it than that. I don't know why. Any questions on this before I leave this?
No.
Pretty self-explanatory. I'm going to go back to where we are missing some categories on there. So I'm going to bring this one up again because it doesn't seem like we had the full sheet. Okay. Does everybody see that? Should be the blank sheet.
Yes.
Yes.
Okay. Sometimes when you change around in here, the share screen doesn't catch up to you. Oh no, this is the example again. Okay. This is an example, but for some reason on my other slide, this section right here was missing. This is the Erickson psychosocial assessment.
Well, all we see on the screen is a white screen.
I only see a white screen too.
Let me stop the share and I'll go back and make sure that we bring up the right one again. I think this is it right here. Yeah, here we go. For some reason on my other example, this part here was missing. This is going to be on your form, your blank form. Erickson psychosocial assessment. There's something like 7 or 8 different categories of psychosocial assessment based upon their age. Now, Erickson's table should be in okay, let me stop this just a second and go looking for it. Nope, sorry, can't do that. I do believe that we have Erickson's table posted for you in Canvas. Yes, we do. Okay, good. Under clinical 1, there is Erickson's developmental stages, a chart of all those. Have you guys been exposed to that at all? Erickson's developmental stages. Does anybody know anything about those?
Think I've
They talk about it.
they
Only
talked
read
about them in
It might have hit
psychology.
on it. You're going to get a lot of mental health during MedSurg 3, so I wasn't sure when. But anyway, here is the chart that is in your Canvas. Basically, Erickson found that people in different age brackets have different developmental issues. For example, from birth to 18-month, the thing that you're most concerned about is feeding, and your issues are going to be trust versus mistrust. The baby's learning to trust the mother. And as you get older, I mean, you get into like adolescence, identity and role confusion. That's the big issues with the adolescents, right? That's why they're on Facebook all the time. They're trying to determine what their role in society is. Young adulthood, you start getting into dating, intimacy versus isolation, and relationships. So every age bracket, you have various developmental stages. Now, you are going to be dealing mostly with senior citizens. So you're probably going, and those usually 65 years and older, reflections on life. They're getting at the end of their life, and that's kind of the issues that they're going to be dealing with. So this chart is in there, and you can use that. I'm going to bring that, share that chart back up again. Okay, it's not there. But anyway, on that form I was showing you, that is one of the things that they are going, that your patient's going to be dealing with. We come back down here, click on demographics again. Here's the blank form right here. Does everybody see this?
Not
No.
yet. No.
There we go. You will now. There.
Yeah.
Okay, here's the blank
Got
form.
it.
This is the one you're going to be filling out. As you see, as you go down here and get to the Cardex, and then here's Erickson's stage again. So you want to tell us what stage they're in, because they may not be in the 65 to death stage. They may be dealing with intimacy issues or family issues or relationship issues. So just pick out whichever stage you think is most appropriate for them and put that in here. Data to support this choice. Usually it's going to, they're 65 and older, they're at the end of their life. You know, that's why I chose that stage. So that's what you'll want to do with this face sheet. Any questions on the face sheet before I dive into the lab sheet?
Okay, for the just Erickson's psychological stage, do we have to go by the age? For example, the patient could be in 60s, but can we put like trust or mistrust stage for that person?
Exactly. If you're dealing with an Alzheimer's patient, and you know how Alzheimer's patients have a tendency to degenerate or even go backwards in developmental stages, you may go all the way back to trust versus mistrust with that person. 90% of the people who are healthy will be in their appropriate age stage, but if you see something that you think is a real issue for this patient, then you can pick a different stage.
Thank you.
Any more questions on any of that?
I might just jump in there about the Erickson thing. Try to get your patient's age, because you might have a person who didn't get past the trust or mistrust, and maybe at a young age, but they still grow and they still go through those other stages too. Maybe because they have mistrust issues, there's not going to be, they're going to kind of mess up on all the other issues too. But kind of look for the age. But the problem is, like Bryce was saying, that if they have Alzheimer's, it's very hard to know what's going on. Are they happy about being old? Or are they bitter about being old? Or do they even know that they're old because they've got Alzheimer's? So that's the hard part right there.
Okay, thank you.
Any more questions on the demographics sheet before we move on to the lab sheet? Pretty simple, pretty self-explanatory.
What's code status? I came in a little late. I didn't know what you meant by that.
The what?
Code status. Status.
Code status, you know, CPR.
Oh, code status.
Yeah.
That's a really good question because I don't think I covered that. The code status, you are basically going to have full code or DNR. Sometimes you'll see DNI. Or you can also have a partial DNR. Patients get to pick and choose. Basically, if they're full code, that means anything goes wrong, you do everything. You do CPR, you intubate, you use chemicals, you put them on a ventilator. You and I are full code. Do everything you need to keep us alive. As the patients get older, they may want a DNR, which means do not resuscitate. That means they don't want any heroic measures done to prolong their life. Now, honestly, if I'm 80 years old and my heart decides to quit ticking, I would probably want to be DNR too. Just let me go. I mean, I'm 80 years old, for God's sake. That's entirely the patient's choice. You can do a partial DNR, and partial DNRs are, you can do CPR, and maybe even use chemicals, but I don't want to be put on a ventilator. So it can be, usually it's one of those three, usually in the run sheets, which is a sheet they give to the nurses when they come on duty. It'll usually either say full or it'll say DNR. And some of them say DNI. DNI means do not intubate. People are afraid of being stuck on a ventilator, and the ventilator just keeps them alive in kind of a semi-vegetative state. So a lot of people don't want to go on the ventilator, and that's their right. Any questions on that?
I have a question. I work at the hospital, and sometimes we see like CMO as the code status as well. Are we going to be seeing those, and where are we going?
DNO?
CMO, like comfort measure, like how they
yeah.
don't want to be help at all, like no pain med, no.
Yeah, a CMO is basically the same as DNR.
Okay.
When you do a consult, we have one patient going through that right now out at Heron Keys. Once they decide to go comfort measures only, you're not going to do any resuscitation on the patient. It's kind of like hospice in a way. Although CMO, the doctor can put the patient on comfort measures only. Hospice is an entire program. You have to get them into the hospice program and everything. But when a family decides to do comfort measures only, it's basically the same as DNR. Any more questions? I will jump into labs, and we will run through the labs quickly here so we don't take up too much time. Down here is everybody, do I still have my canvas up? Does everybody see my canvas?
Yes.
Yeah.
Okay. This is the lab sheet form right here. There is an old one running around out there. The old one will have two columns that say date and result, date and result. That's the old form. You can throw that away. We've changed it so that now that you use a separate sheet for each set of labs a patient has done. But basically, it's pretty simple. We have the, I'm going to move my box over here out of the way so you can see this. We have a list of the more common tests and some of the less common tests on this sheet here. And you're going to fill out the normal value, what the normal values for that lab are. You will then put the date and time of the patient's lab, the patient's result, and what is the significance of that test? Now, the significance of the test, what we're saying is, what is that test normally used for? And this will become clearer when I show you the example. Over here, what does this value mean for your patient? If your patient's value is in the normal range, you can just simply say it indicates that there's nothing wrong with that patient's kidney or whatever the test is for. However, if the patient's lab value is higher than normal, you have to explain to me what that means for the patient. Why is that lab value higher? Why is that lab value lower? So that's what we're looking for here. Now, that being said, let me stop the share here, and I'm going to go in and bring up, let's bring up the example sheet again here. I'm going to go ahead and I guess I could still do that within the Canvas. Okay, I'm still figure out where I've got all my stuff here. So in Canvas, I put that example sheet. If we go down right here where I put face sheet and labs example, I'm going to bring that up again. Move the box out of the way. And if you go down this example, which I just showed you for the face sheet, below that is a lab example. Boom. Now I cut off the rest of the sheet because I'm only going to give you one example. You guys have to fill out all the rest of them. So I'll go back and I'll show you that here in a minute. But I wanted to give you an example. So I did PT for you, prothrombin time. Now, the normal value of prothrombin is 12 to 14. Now, the patient had a test done, say, on 6/18, and the result of that prothrombin time was 18. Now, over here, significance of the test, you can fill that out ahead of time if you wish. And I'd probably recommend that you do that so that it's already filled out and you don't have to worry about it. And then over here, okay, the person's, let's say their PT value was 10. What does this mean for my patient? Well, it could mean that his kidneys are failing. It could also mean that their liver is failing. As you can see in the explanation here, liver prothrombin is manufactured in the liver. So if his PT is low, he may have liver problems. But that's what we're looking for on the lab sheet. You're going to have to fill in, we're giving you the lab test. You'll have to fill in the normal lab values, and you'll have to fill in the significance of the test. Now, you only have to do that for the labs that are run on your patient, of course. Let's go back to the blank sheet so I can show you what I'm talking about. If you go down to paperwork in a nutshell and bring up the lab sheet, you will see that the lab sheet is blank. And if your patient had a coagulation panel done on them, and I'm going to talk about that here in a minute with the PowerPoint. If they have a coagulation panel done on them, they're going to test their PT, their PTT, and their INR. So you'll want to put the normal values of that lab in here. You'll want to put the date and time of the lab result and what the patient's result was. Over here, you can fill out what is the significance of that? What's that? Anyway, here you'll say, this category here is why did we run that lab on that patient? And then over here, if their lab value, what it means in reference to that patient. If it's normal, you can say, well, patient's coagulations are normal, whatever. just don't put don't apply or normal. If you put normal, Bill will kind of get upset about that. He wants you to put a little explanation in there. But as you have patients that have their tests, the more common tests, you'll fill out the significance of the test category. Keep that and keep that as a blank so that the next time, the next patient you do, you don't have to fill this out again. Some students even went through and filled out all the significance of the tests on all these labs. Now I'm going to go through a PowerPoint and talk about some of the more common labs. And the information I'm giving you in the PowerPoint, you can use right here. So as you fill these categories out, keep them as a master sheet. So the next patients you get, you don't have to fill in the normal lab values again, and you don't have to fill in the significance of the test again. You'll already have it written out there. Now, some of the more common tests are going to be the coagulations, the electrolytes, the whole blood, H&H and all this. So these are going to be the more common tests that they're going to have. What you will not find, oh, we do have a urinalysis sheet. Okay, we added, you didn't used to have a urinalysis sheet. So, but we do have one now. And then other labs that the patient had done on them that we might not have listed, you can put down here. So that is the blank lab sheet. Any questions on that? Pretty straightforward. That being said, what I'm going to do is do a real quick PowerPoint for you here. Now, if y'all are happy with that and you know you don't really want to stick around for this PowerPoint, you don't have to. But what I'm going to do in this PowerPoint is I'm just going to go over some of the more common labs that are on that sheet that we gave you. Okay, just talking about the lab sheet in general, it needs to be filled out. You only have to fill out those tests that your patient got. You don't have to fill out all the tests. And this tells you what the categories are. Places where you can find the information. It's most likely going to be in their computer. You know, almost every place we go now, they're going to have computerized records. So you just look up their labs, they'll be right there. Now, something that I need to point out, first of all, normal values are going to differ from lab to lab. Now, one lab may say a PT is 12 to 14. Another lab may say it's 12.5 to 13.5. There is no universal normal value for labs. Normal values differ from lab to lab. So when you look up the patient's labs, the lab that produced that lab is going to give you their normal values, which are, you know, if you've copied down the normal values from, say, your textbook or something, that's fine. The point I'm trying to make is the normal values are not going to be spot on. They're going to differ from place to place, record to record. So, you know, we're not going to really, if you put down 12 to 13.5 for the normal PT value, I'm not going to mark you off for that. I mean, that may be what that particular lab's normal values were, but they're all always in the same ballpark in general. They usually only differ by about 0.5 to maybe 1 from each other. So it's always a point of frustration for a lot of the students because they say, well, that's not the normal value I've got in my textbook. And no, it's not going to be. The normal values change from lab to lab to lab. So there's no universal normal value, but there is a ballpark figure. And I'm going to go over those as we go through here. Okay, first of all, we're going to talk about, these are the labs I'm going to talk about really quickly. Because these are the ones you're going to probably see on 90% of your patients. The BMP, CMP, Chem7. Those lab tests there, it just depends on the number of tests they do. Some only do 7, some do 12. It depends on how much of it, and I'll talk about that in a minute. But those look at electrolytes. Those are looking at your calcium, your potassium, your sodium, your chloride. That's what those look at. The one below that, the CBC, is our whole blood products, red blood cells, white blood cells, etc. Coagulations, that's what we give to patients that are on Coumadin, warfarin, heparin, etc. And below that, urinalysis, well, that's the P-test. And that tells you a whole lot of things about a person. So that's a really good test right there. Let's start off with the BMP, CMP. Now, if you go to a doctor and you get your blood drawn, he's probably going to do a metabolic panel on you. Now, BMP stands for basic metabolic panel. That is about 7 tests that measure your electrolytes, your urea, and your blood sugar. Used to be called Chem7, but they added calcium to the test. So instead of calling it Chem8, now they call it basic metabolic panel, BMP. Now, you probably see a lot in the hospital is a CMP. And what that is that it's a complete metabolic panel. In other words, they added 6 more tests to the basic metabolic panel, 4 liver enzymes and 2 proteins. And we'll go over those here. A lot of doctors use what's called a fishbone chart. These fishbone charts are a shorthand that doctors use to write out the lab results, just because it makes it simple for them to keep track of. Some ICU nurses I know have used it. You may not. You know, most people in med surg and stuff, they don't use them, but I'm just going to show, I wanted to show that to you so you knew what it was when you see the doctor's scribblings all over the place. The first 3 things in a basic metabolic panel or a complete metabolic panel are the potassium, the sodium, and the chloride. Potassium is an extremely important electrolyte. You probably had, I'm not sure when you're going to get this. Have you had this already? Electrolytes? No? Yes?
No,
No? Okay. Well, you will get it. Anyway, potassium is very important. Electrolytes are especially important in operating the pumps in the body, like the heart pump and muscle pumps, because it's the exchange of electrolytes that stimulates the muscle to contract. The reason this is so important is because this potassium is very important for your heart pump. So if this potassium gets too low or this potassium gets too high, your heart quits working. Normal values are normally 3.5 to 5.3. There again, this is information that you can use to put on your lab sheet. So this PowerPoint is uploaded to Canvas. You can come back here anytime and reference it. So if you have a patient that gets a complete metabolic panel, you can come back to this PowerPoint to help fill in the information on your lab sheet. This is pretty generally, that's pretty close right there, 3.5, 5.3. You might see, 3 to 5 or whatever, but that's pretty much the general normal value for potassium. I used to do dialysis, and if a patient's potassium gets too high, they have a heart attack. So if you see a patient's lab value of potassium that are up around 6 or 7, that's dangerous. That's an emergency. They should be going to the emergency room or to the hospital if you see that. And in dialysis patients or patients on kidney failure, you'll see that a lot. You'll see their potassium level going up, and that's dangerous. So keep that in mind. There again, what does potassium do? Polarize and depolarizing. It's the polarizing and depolarizing of the muscle. That's what makes the muscle pump and contract. If your potassium is too high in the heart, your heart's going to do crazy things and you're going to go into VTAC or VFib and have a heart attack. So high potassium is bad. Keep an eye on the K. Yeah. Anytime you start getting above, get about a 6 or so on potassium or down below, say a 2.7, you should be calling the doctor on that. Now, some of the other electrolytes, like we're going to get into some other electrolytes, that's not as important. You know, it's not life-threatening right away. Some things that cause low potassium, hypokalemia, vomiting, diarrhea, high doses of insulin. And here's some of the symptoms like muscle cramping and EKG changes. And you can go back over this later if you really want to look at it in more detail. Hyperkalemia, 90% of our potassium is stored in our cells. So anytime you have anything that breaks cells down in the body, like a crush injury or a burn, it's going to release potassium into the bloodstream. So most people probably won't think, oh, this person had a 3rd-degree burn over part of his body, we should keep an eye on his potassium, but that is something you might want to do. And of course, kidney failure. Kidney failure will cause your potassium to go up. Cramping, severe cramping in the lower legs and cardiac dysrhythmias is a sure sign that the potassium is off. So if a kidney failure patient starts complaining about cramping in the legs, I might want to call the doctor and ask if we can run a lab on them. On the fishbone, this is where you would put it on the lower left corner. I used to go into the fishbone a whole lot. I'm not going into it anymore because I don't think most people use it anymore. Sodium, good old salt. Normal level is around 135 to 145. Salt and water go together. So if you're dehydrated, you're probably losing salt as well. Which is why in the military, they used to give you salt tablets because you were sweating out salt as well as water when you sweat. What can cause salt to be too high? Too much sodium in the IV. Dehydrated, that's because if you lose water without losing the salt, then of course your salt level is going to go up in your bloodstream, to logic. A lot of electrolytes are affected by different hormone systems. And when you study the hormonal system or the endocrinology, you'll learn how this affects everything. But somebody with Cushing's syndrome, they have a tendency to retain sodium. Hypothyroidism, the other hand, the opposite of Cushing's syndrome, can result in your sodium being too low. Also, diuretics. Diuretics can cause you to lose electrolytes. So hormone imbalances and diuretics are the two big culprits when it comes to your electrolytes being out of whack. And that's where it goes on the fishbone. Chloride follows sodium. Usually if your sodium is low, your chloride's low, etc. Here's the normal value, 98 to 106. Diarrhea is a big culprit. If you diarrhea, you have a tendency to lose a lot of electrolytes. And then here's some causes again. Kidney disease, Cushing's syndrome, then again, another electrolyte. Thiazide diuretics, another diuretic. These are good for affecting your balances. So you can always refer back to this chart again. If you find that the chloride's low in your patient, and you look at this, you might find out, oh, my patient's been vomiting for a week. Okay, well, that explains why his sodium is low or his chloride is low. Goes here on the fishbone. BUN, blood urea nitrogen, that's your urine. It's your urea. Normal values can differ widely, as you can see here. So go by whatever lab company that is doing it on your patient. Use their normal lab values, but it differs widely. But basically what it reflects is this is a waste product from protein. When you are digesting food and breaking down and getting waste products, BUN is one of those waste products. It floats around in your bloodstream and you pee it out through your kidneys. So if your BUN in your bloodstream is going up, that means it's not filtering out, which would mean what? How about your kidneys are failing? BUN and creatinine go together. Now, creatinine is also a byproduct of muscle breakdown, but then again, just like BUN, it's a waste product. Normally, you shouldn't have a whole lot in your bloodstream. 0.6 to 1.3 is a normal value. Anything over 1.3 could mean your kidneys are failing. So in other words, BUN and creatinine normally go together. And if those are going up, it means your kidneys are failing. That's the basic significance of that test right there. And that goes on these two brackets here on the fish chart. Carbon dioxide, normal value 23 to 29. You'll see these values differ in respiratory patients, obviously. Patient with COPD, first, maybe somebody with pneumonia or whatever, you may see those values go up. Now, one thing I want to point out with these lab tests right here is these CO2 is important in your acid-base balance in your body. Have you guys studied blood gases, arterial blood gases?
Yes.
Yes, okay. These labs that I'm talking about are venous. We take them out of your vein. Arterial blood gases come out of an artery. So the CO2 value on a blood gas is going to be different than the CO2 for a venous blood draw. So just kind of keep that in mind. If someone says, wow, their CO2 is 30, the first question you might want to ask them is, well, is that an arterial blood gas value, or was that from their venous draw, their basic metabolic panel? Now, the last thing, now this is a Chem 7. This fishbone here is a Chem 7 or basic metabolic panel. The last thing on there is blood sugar, which if you don't know much about it right now, by the time you get done with Eileen's class, you're going to know a whole heck of a lot about blood sugar, because they were talking about diabetes. You're going to get totally inundated with blood sugar, so I'm not going to spend a whole lot of time on it. But of course, if you get too much insulin, that drives your blood sugar level down. People not eating, their blood sugar going. You always hear people, "Oh, I'm hypoglycemic. I haven't eaten. Give me a candy bar." Yeah, that lowers their blood sugar. Too much blood sugar in their bloodstream is diabetic, usually diabetes. Their blood sugar is too high. They can be diabetic. But there's other things that can release extra. Your body stores glucose in the form of glycogen in your liver. In times of stress, this is like an emergency backup plan for your body. In times of emergency, your body may release that glycogen from the liver, and that converts to glucose and gives you extra energy. You know, when you're in ancient times when the mountain lion was chasing you, you know, you had to come up with that extra energy to escape. So things like trauma and stress and stuff will release the glycogen from the liver and make your blood sugar go up. Not good if you're always in stress. Not a good thing. But mostly it's usually, this is one of Eileen's slides because it says trick or treat gone bad. Too much sugar. So you're gonna get totally inundated with that in Eileen's diabetes classes. So there it is. That's the Chem 7 or the basic metabolic panel right there in a fishbone shortcut abbreviation. I'm not sure what you call that. So any questions on that? I'm not going to touch on the complete metabolic panel with the liver enzymes and the proteins. But if you do a CBC or a CMP, a CMP, it includes additional liver enzymes. Basically, the thing there is if the liver enzymes are elevated, you have liver problems. But I'm not going to go into detail on that right now because I just want to hit the basic ones. CBC, complete blood count. This deals with your whole blood products. Now, there's the what we call the H&H, hemoglobin and hematocrit. We're also going to talk about white blood cells, and we're going to talk about platelets. This is the fishbone that doctors use for keeping track of those labs. Hemoglobin basically is just how many red blood cells you have in your bloodstream. Men should have 14 to 18 grams per deciliter. That's how many red blood cells we actually have in our bloodstream. Women should have about 12 to 16. Their level is a little bit lower than men's. Now, things that cause high blood pressure or high hemoglobin levels is like high altitudes. That's why athletes train at high altitudes in Colorado, because it develops more red blood cells. That's how the body adapts. Low red blood cells is anemia. Have you guys had anemia yet? Maybe not. You'll get it. There are many different types of anemia, so it's going to depend on what the cause of the anemia is. Anything from you lost blood in a car accident to hereditary dysfunctions. This is where hemoglobin goes on the fishbone. Hematocrit, however, is not a measure of how many red blood cells you have. It's a measure of what percentage of red blood cells you have to the rest of the stuff in your bloodstream. So red blood cells as compared to plasma, white blood cells, and everything else that's in your bloodstream. It should normally be in the range of 50-50. You should have half red blood cells and half plasma and white blood cells and platelets and other stuff in your bloodstream. It's a balance, in other words. So when we're looking at hematocrit, we're looking at men about 40 to 50%, women about a little less than 40 to a little less than 50%. There again, the women, since they have less red blood cells, their hematocrit's going to be a little bit lower. Now, one thing to note about, well, before I get to that, I'll just do here. Things that can cause the hematocrit to be high is dehydration. The water is in the plasma. If you lose plasma, it's going to make your hemoglobin count look higher, right? So that's why the H&H or your hematocrit can appear bigger if the person is dehydrated. It'll look lower if you have anemia. If you have less red blood cells, more plasma, it's going to make it look lower. Something I want to point out here, and you're going to run into it in your career, is the hematocrit. 99% of the time, the hematocrit is 3 times the hemoglobin. So if you have a hemoglobin of 10, you'll have a hematocrit of 30. Just a quick reference. If somebody ever asks you what the hemoglobin is, but you only have the hematocrit, you can do the translation there. But the hematocrit is almost always 3 times the hemoglobin in a normal person. See, if that ratio is off, that can tell us something about the person as well. White blood cells. I'm not sure if you've studied white blood cells yet or not. You will be, we'll beat you to death on white blood cells. Don't worry about that. There's 5 different types, but the important thing here is 5,000 to 10,000 millimoles cubed is what the normal value is. Now, quite often, let me see. Yeah. Quite often when the lab values are like 1,000, we don't say their normal value is 5,000 to 10,000. We say their normal value is 5 to 10. And in this over here, they would put a K for 1,000. So if somebody says, well, their WBC is 8, you have to think 8,000. So just a shorthand we use. Mostly white blood cells just hang out, eating up all the bad things and all the infections in your body. And you're going to, in fact, I teach that module. I'm going to teach you what each of the different components of the white blood cells are and how they operate. On the fishbone chart, it goes over on the left side here. And here you can see 4.5 to 11. Now that means 4,500 to 11,000 is how you would read that. Platelets are help your blood clump. When you cut yourself in the shop and your blood is streaming out of your body and it clots off, this is what the platelets are doing. They live about 9 to 12 days. Normal value is 150,000 to 450,000. There again, that's going to be abbreviated to 150 to 450 when you see it recorded on a chart. Here it's just talking about the abbreviated value. High platelets, there's a variety of things. It's usually some dysfunctions like polycythemia vera or cancer that affects your platelets. There again, cancer, the stuff is made in your bones. And if you have lymphoma, cancer in the bones, it's going to affect your platelets. But lack of B12 also can do it. but we'll be getting into detail on that in the future. And this is where it goes on the fishbone. Any questions on the CBC? Almost every patient that walks through the door, they're going to get a metabolic panel and they're going to get a CBC. We just do it on everybody. We probably do it on their family when they walk through the door. You go to the doctor, he's going to do a metabolic panel and he's going to do a CBC. They tell us a lot about your health. I'm not going to get into detail on that because we are going to study each and every one of these when we get into the immune system. But the doctor may say, I want a CBC with a diff. What he's saying is a CBC with a differential. Now, what the differential does is it just takes those WBCs that we were talking about earlier and breaks them down into their respective components. But in future classes, we're going to talk about exactly what neutrophils do, what lymphocytes do, what monocytes do, etc. So we won't worry about that right now. It's a cute little acronym though. Never let monkeys eat bananas. That's a way to remember what the 5 components of WBCs are. I hope I remember that when I get to the teaching that thing. Now here again, here's the neutrophils, lymphocytes, monocytes, eosinophils, and basophils. I'm not going to go over those right now because we'll get to them when you get that class in that. And I really am going much over what I wanted to go. Last thing I'm going to talk about here are coagulations. If a patient is, why this is so important is because so many of our patients are on heparin or Coumadin or warfarin. And the reason being is one of the most common dysfunctions or diseases in our society today is a heart attack, right? But what's a heart attack? It's a blood clot in the heart. They have a stroke. What causes most strokes? A blood clot in the brain, DVTs, pulmonary embolisms. So many of the things that are killing us today have to do with the coagulation of our blood. So we have a lot of patients that are on anticoagulants. If somebody has atrial fibrillation, they could be on an anticoagulant. So we're going to test a lot of patients on their coagulations. Now, a coagulation panel would normally do these 3 tests, and they each kind of, here's the fishbone again, or what we use, it's my little rocket, or my headless, armless man, whatever you want to call it. Each of these tests kind of affects a different medication than what we use. The PT was not used as much today. It used to be used for warfarin, but now we're mostly using the INR for warfarin. So the PT is not as important as it used to be. But there again, it just takes it. The normal value is tested in time. They test how long it takes for the blood to clot. And prothrombin time, it's done in time. In other words, 10 to 13 seconds for that to clot. And that's how we get the prothrombin time, normal lab value, I should say. Like I said, we used to use it a lot for warfarin. I don't know if we use it as much. I don't know, Eileen, if we still use it or if we're using the INR for the warfarin now.
No, I think for the PT, the PT and the INR are just married now. They're always together. So when you want to check for the medication morphine or whatever, they just look at the INR. But if they want to look at other things, they look at the PT, but whether they want one or the other, they still do both.
Okay. Yeah, they do all 3 tests, but
yeah,
I know as we move on to PTT, the partial prothrombin time, this is what we use for measuring heparin. Now, people aren't going to go home on heparin. We do heparin in the hospital. But if somebody had a stroke, if somebody had a heart attack, if we want to prevent DVDs after a surgery, we use heparin IV. And there's a whole chart that's set up as to how often you give it, how much you give and everything. That'll be done in the ICU. So you're not going to probably be exposed to it for quite a while now, or at least until you get your RN. But it takes 25 to 35 seconds for prothrombin time to take effect. That's the normal value. Now, if somebody is on heparin therapy, what we want to do is we want to extend that time because we don't want them to clot as fast. So, but that's all going to be in a bunch of charts and graphs that you use in ICU. So wouldn't worry too much about that unless your patient is on heparin. That goes here on the fish chart, and 25 to 35 seconds is the normal value. Now, after that patient's no longer on heparin and we're sending them home, and we want them to be anticoagulated because we don't want them to throw another clot, we'll send them home on warfarin or Coumadin, or there's a lot of prescription medications now that keep them from clotting off. And what's nice about some of the newer prescription medications is we don't have to test them all the time. But if they do go home on Coumadin, we have to test them usually once a week or twice a week. I have a patient right now in our clinicals. She gets her, now INR is the test we use if the patient is on Coumadin. And international normalized ratio is what the INR stands for. And normally it runs below 1, I think 1.5, what was the normal value? 0.08 to 1.2. That's for you and me with our normal coagulation. Now, if we're sending the person home on Coumadin, we don't want them to clot. So we want that value to be higher. And this is a number that will be ingrained in your head for the rest of your life. Normal therapeutic value for somebody who is on Coumadin, their INR should be 2 to 3. And you used to have to go get a lab test in the lab and they would measure your INR, and that was a pain. Now they have a little machine that's just like the blood sugar machine you're going to use for diabetics, where you can poke your finger and get some blood and put it in this machine, and it gives you the INR immediately. That is a godsend. That really is. It saves them having to go through a whole lab or having to draw blood in order to get an INR. So you will be seeing that in your lab, in your clinical rotations. We'll be taking INRs on the patients. But this is going to be ingrained in your head. If your patient is on Coumadin, you want their value to be 2 to 3. If it's too low or too high, you let the doctor know, and so that he can adjust their Coumadin to get them into 2 to 3 range. Some things you don't want to eat as far as foods go. Oh, you have an INR meter, Eileen? Wow, I didn't know we had.
Yeah, we do. We got them. We got a special budget, so we got 2 of them, so we can even practice at school.
Awesome. Certain foods, vitamin K. Vitamin K is used to help your blood clot. So, of course, if you're on Coumadin and we don't want your blood to clot, we certainly don't want you to eat food that has a lot of vitamin K in it. So that's something educational that you'll have to inform your patients about when you send them home on Coumadin. Any questions at all on the coagulation panel? So we've covered the metabolic panel, the complete blood count, and the coagulation panel. I will cover the urinalysis later because we're out of time. But when I get to genitourinary, which will be next quarter, when Eileen and I in MedSurg 2, I'm going to beat you to death on the urinalysis, so you don't have to worry about it. You'll learn all about that. Anybody have any questions? Because we've hit our hour block now and we need to let this go.
Yeah, I do actually. So I saw that the assignment is due on June 22 now for this demographic and lab sheet.
Yes.
So we do have to fill it out. So where do we find the information?
No, there is no assignment.
Oh, okay. So we don't have to fill it out.
No, there's nothing to, if you look, you'll see that that's worth 0 points.
Okay.
When Bill put these modules in Canvas, he put them in as an assignment.
Okay,
Because he is going to be doing an assignment when he teaches you pathophysiology.
Okay. So for right now, we can just ignore that one.
Ignore it, just ignore it. And when Eileen teaches you her 2 classes, she also has hers assignments also. And it's going to be up to Eileen as to whether or not she wants to assign anything to you.
Okay, and then until then, you guys will tell us where we can find the information to fill it, right?
you'll be filling this information out on your patient when you get into clinic.
Oh, okay, so just not as, okay, that's making more sense.
And we'll probably let you know before you actually go to clinicals, but you want all this paperwork, hard copy in your hand when you walk into the clinicals your first day.
Okay, and I know,
You're gonna start filling all this information out on the patients.
okay, and I know I read on the syllabus that is have to be typed, but we can write it with the black pen, no? I think I read it somewhere that is have to be typed up, but maybe I was wrong. Just
Well,
No, we normally want you to type it up and then
Oh, okay.
upload it to your assignment in Canvas.
Okay,
There were some cases where we made an exception, and Eileen, you remember what that was?
Yeah, I think the big reason why we're having you type it so we can read it later. And, you know, you put some thought into it. I think, you know, like the whatchamacallit, sometimes the assessment sheet, that's hard to type in, but I think we want to keep things tidy, so that's why we want the typing.
I'm gonna
Okay.
stop the recording now.
But, you know, if
Maybe I
something
should.
happens that your computer breaks down, write it out. There's no sin with that, but I think
Yeah.
the reason why they want to type so we can read it.
okay, that's making sense.
I
Thank you.
have seen people do their patho sheet. Now, the patho sheet is very narrow. And they think they want to fit that whole paragraph of information into like a 1/4 inch. And they're like scribbling, you know, micro print on here. No, you can't do that. I mean, you know, you at least have to print out a copy where you expand it so that you have enough room. But I've seen some really bad scribbling. So yeah, we really prefer that you have everything typed and handed in. If
Okay,
you go on to our end, they will not accept any handwritten copies of anything.
okay, thank you.
Question?
Are there any examples on how to create our binder that we're going to take with us to clinicals, or how to organize our papers?
There is no set order. As you saw on Paperwork in a Nutshell, there are 7 sheets. I'm not really picky about what order you put them in. Of course, you want the demographic sheet up front first, but just basically the order that they're in that Canvas module.
Okay, thank you.
Yeah, I mean, it's just basically you're going to take all of those sheets, and well, you're going to upload them anyway to Canvas. But yeah, we're not really picky about the order. Anybody else?
Quick question: when downloading the files and trying to open them up, for at least for my computer, for my MacBook, it's not letting me open it up in any kind of other form. It's like in this weird tiny format that I think Apple uses for documents. Is there a way to make it open up in like a Word document or Excel spreadsheet?
The most of the documents should be Word. I know the concept map is really weird. When you open it up on the screen, it looks really funky. But when you download it and open it up in Word, it looks normal.
Okay.
Are you using Apple?
Yes, I'm using Apple. I'll speak with my peers and just ask them how they're dealing with it as well, if they already have remedies or.
Okay.
I have MacBook as well, but I have Microsoft Office on my MacBook.
Yeah,
So when
I
open it-
think as a part of your nursing curriculum, you're required to be using Office. if I'm not
Correct.
mistaken.
And usually everything that I've opened up all of first quarter, even up to now, has been uploaded to Word. But for some reason, when I tried downloading these specific lab files, it's opening up in a weird concept. But I'll reach out to my classmates and see what they're doing or how they.
Okay, yeah, and if you can't, let me know. Maybe I can download it to some type of file format and just send it to you.
Okay, I appreciate it. Thank you.
We'll get you to the information one way or the other. I'm going to go ahead and stop the recording now.